Well, so I want to talk to you today about something that's obviously very close to me professionally, and that is the role of corneal transplantation in patients with MPS. I do consult with Sanofi Genzyme, but not related to this topic. So most of you know that patients with MPS, often have eye problems, and that it really varies depending on the type of MPS the patients have. And I'm just going to, again, focus a little bit on some of those issues, but again, mostly on corneal transplantation for patients with cloudy corneas. As mentioned earlier, my interests in MPS go back 30 years. I was a medical student at the University of Minnesota, and was fortunate enough to work with some of the people here, which you may recognize on the paper, like Dr. Summers in particular, part of the reason I became an ophthalmologist, and Dr. Chat Whitley and Dr. Krivet, who was mentioned in one of the previous talks. And this paper actually looked at bone marrow transplant, the role of eye changes after bone marrow transplantation, and I think was one of the early papers to look at this particular topic. Now, I'm going to do a quick anatomy lesson, just because we're talking about the eye and specifically the cornea. So the cornea is essentially the clear dome that covers the surface of the eye, and we see our iris through that, which is the colored part, and the sclera, which is the white part, and there's a transparent membrane over that sclera called the conjunctiva. And our retina is essentially the film in the back of the eye, which feeds the optic nerve, which sends the information to the brain. So as I mentioned before, ocular manifestations are very common in mucopolysaccharidosis, and they can involve the sclera, the cornea, the trabecular meshwork, which is involved in glaucoma, which is a high intraocular pressure. The retina can be involved, the optic nerve can be involved, and so can the visual pathways to the brain. So oftentimes, the eye findings are some of the first diagnosis to be recognized, or first symptoms to be recognized before the diagnosis is made, and that may be the case for some of you in the audience. And particularly as treatments have improved and we're seeing patients living a lot longer, the actual eye problems can get worse over time. So there is a need for eye exams, and depending upon how patients who may have received bone marrow transplantation, if they received total body irradiation in the past, they might have other issues like dry eye syndrome or cataracts. So again, most of the subtypes do have eye conditions, but the most common ones are type 1, type 6, and type 7. And commonly, patients will have they'll be very hyperopic or farsighted. There'll be corneal clouding. They can have blood vessels in the cornea, retinopathy, which can be of various types, glaucoma, which I mentioned, which is elevated intraocular pressure. They can have swelling of their optic nerves, which can be due to increased intracranial pressure or compression of the nerve right around where it enters in the eye from the accumulation of the mucopolysaccharides. And they can have hypertelorism, which is just a far separation of the eyes, as well as lazy eye, which is amblyopia, and eye muscle issues. And again, all of this is usually attributed to the accumulation of the glycosaminoglycans in the various tissues around the eye. This is a common diagram or table that we often show, showing which of the MPS conditions have the different involvement in the eye, with corneal clouding, of course, being what we're going to focus on today. This is just some pictures. Again, most of us are not looking at fundus photos of the eye, but the yellow dot in the upper right-hand corner is a swollen optic nerve, and after the nerve has been compressed for a long time, it will essentially die, and it'll have that bright white appearance, which you see in the lower right-hand side. The corneal clouding that you typically see in MPS can be quite variable. So all these patients have Morquio syndrome, but the degree of clouding can be highly variable, and I think that's one of the primary messages I want to leave with you today, is that even though you might have an MPS condition that is associated with corneal clouding, the corneal clouding is very variable, and therefore the impact on vision is very variable. and essentially means that just because you have MPS or just because you have some corneal clouding, it may not mean that you have to do anything about it. It may be okay just the way it is. We've talked a lot, or a lot of the previous speakers have talked about enzyme replacement therapy and the role of bone marrow transplantation in management of MPS. And basically, studies have suggested that these treatments actually will improve or slow the progression of some of these ocular manifestations. And that's been shown particularly in some swelling around the nerves, but not really affecting the retina. And the retina is really kind of a brain tissue in the eye. And as mentioned by several of the other speakers, that's the hardest to treat. So the retinal degeneration, we don't normally see any changes in that portion. In terms of enzyme replacement therapy specifically, there's a lot less data out there about the impact on the eye, but the studies that are available do suggest that it does stabilize the impact on the corneal clouding and the impact on visual acuity. Again, if patients have had bone marrow transplantation associated with total body irradiation, they can develop cataracts after the surgery. They can also develop severe dry eye conditions as well, and that would require additional management. And if patients who have had transplantation develop graft versus host disease, those can lead to a whole other series of eye complications, which might include even corneal perforation. So in terms of corneal clouding itself, as again I mentioned before, we see this most commonly in MPS 1, 4, 6, and 7. And obviously we recommend for all MPS patients to get annual eye exams. Now, when the corneal clouding gets to the point where it is affecting vision, really there's not a whole lot of options for those patients other than considering corneal transplantation. And essentially, for corneal transplantation, there's essentially two choices. There's what's called penetrating keratoplasty. Sometimes we abbreviate that as PKP. And then deep anterior-lamellar keratoplasty, or DALK. And one is a full-thickness transplant, and one is a partial transplant. And again, as I mentioned before, just because someone has corneal clouding, it doesn't mean they're going to need a corneal transplantation. And obviously, several of the other speakers mentioned the anesthesia risks associated with that, and one needs to really consider the risks versus benefits of the surgery and understanding that there are also other eye conditions at the same time that could impact the amount of improvement in vision after the surgery. So those are all things to think about. The other thing to think about is the impact of the postoperative management, which is not always easy and may require additional anesthesia to help manage the condition. The good news is that there are many studies coming out now that do suggest that corneal transplantation can be successful. Now, anatomy lesson number 2, the cornea. The cornea is just consists of 5 layers, and essentially it has, like maybe the easiest way to think about it is a piece of toast. You've got like peanut butter on top, which is your epithelium. You've got a crust, which is a dense layer of collagen. You've got the fluffy part in between, which is the stroma. So I just lost my image here. You can, okay, good. And then another dense layer of tissue called Descemet's membrane, and then a thin layer of what is it doing that? Thin layer of endothelium, which is the layer that essentially are sump pumps that pump fluid out of the cornea. So let's talk about penetrating keratoplasty. Again, this is a traditional way of doing corneal transplants. It's been done for over 100 years, and it basically replaces a partial replacement of the cornea in terms of the central portion of the cornea, but we replace all 5 layers. It does require sutures to hold the corneal in place. And this is what's had the most studies for MPS. Now, in the past, corneal transplantation was considered less successful in MPS patients, but some of the new studies suggest it can be quite successful. The other procedure, which is a newer procedure, is the deep anterior lamellar keratoplasty, or DALK procedure. This really has only been done on any kind of regular basis for about the past 20 years. And in this case, we're replacing 3 of the 5 layers. And this is essentially about 90 to 95% of the cornea. I'm just leaving these 2 very thin layers at the bottom. Now, this also requires sutures, very similar to a full-thickness corneal transplant, but they can be removed sooner, which is one benefit, but there's a lot fewer studies in this particular area and outcomes for patients. So the DALK procedure, I'm going to, okay, we'll skip that for a second. Some of these images are not coming through for whatever reason. Yeah, so anyways, the DALK procedure was just a series of photographs I was trying to show, but that did not show up there, so I apologize. But anyways, there's the management issue is important to understand for this. So usually when we do a transplant for patients, immediately after the surgery, the vision's actually worse. Most people see worse immediately after the surgery. That's because the cornea is swollen, there's sutures, and that needs to improve. And that usually takes weeks to a few months to happen. And even when everything is done, the patient probably still needs glasses for optimal visual correction, or in some cases, even a contact lens. Follow-up is usually done for the purposes of, okay, should have transferred this on here. Are you, okay, you can see and I can't. Let's look out here 1 second. Oh, there we go. Okay, follow-up is important to understand as well. We mostly do this to check healing early on, but then for suture removal later on, and basically we see people a day, a week, a month afterwards, and every few months after that. And then, basically once you get past a year or so, we see people once or twice a year for life. I'm sorry, again, you're seeing and I'm not, so I'm going to hold on here just a second. I see, this is maybe a Mac issue. A Mac and PC, I think, issue here, so. I apologize. Let's see. I might have to either load this, maybe, can I get your help for a second? Let's try that. Wow. This keeps popping up for whatever reason, even if I keep closing it. Yeah. Yeah, it's not showing the images for whatever reason. Should I just download it onto the...
Try clicking there.
There. Apologize, 1 second. Show up. Let's try that. There we go. Okay, sorry. So I'm just going to back up for a second. This is the DALK procedure. I think it's very important to show this. But basically, these are just step-by-step procedures how we do this. We essentially mark the cornea. We do what's called a partial trephination. So we're going down about 2/3 of the way to 3/4 of the way into the cornea. You can see we're focused on the central part. We then inject air into the cornea, and that's that whiteness that you see there. It creates a bubble, and basically splits the cornea between layer 3 and layer 4, and then we selectively take off that top layer, and then we basically apply the new transplant on top of that and then put in the sutures. And I'll show a brief video of that in just a minute. Again, medications, people need antibiotics and steroids afterwards, and then basically people take a steroid drop for life to basically prevent rejection of the transplant. This is for both PK and DULC. Obviously, these are not risk-free. Complications can occur. Graft rejection, infections, broken sutures, glaucoma are all things that have to be monitored. This is the study I was talking about earlier, which basically looked at, it was the largest study done to date on keratoplasty in MPS patients. And they looked at 43 patients, or 43 eyes of 32 patients with transplantation. Now, most of those were full-thickness transplantation, with only a very few number of these being DULC. But they did show visual improvement in most patients, 63%. The graft remained clear in 94%. A rejection was still 23%. That's about average for full-thickness corneal grafts. And there were more comorbidities, which could be any of the things I mentioned before, in about 2/3 of the patients. But the important point is that the patient's corneas remained clear with visual improvement of most patients. That was published last year in the British Journal of Ophthalmology. Now, I want to show you just a few cases of patients who I've seen over the years. This is one of the first. He was a 17-year-old high school student who came to see me with Hurler Shea and basically having difficulty with his vision at night, having difficulty with schoolwork. He wanted to go on to college and wanted to, see better, having problems. He was very farsighted, as I mentioned before, and this is doing this again. His corneas were very thick, so it's not that important, but important to understand here. And basically, he had a lot of corneal clouding, although the rest of the exam looked pretty good. These did not show up. I'm gonna, again, okay. Well, unfortunately, you cannot see his images. This is giving me problems. Sorry, this is not. I can't. It's kind of frozen again. I can't. Yeah, it's just frozen. It won't do anything. It's a PC thing. This is, I can't even close it.
I don't even see it.
No, there's no mouse. There's no nothing. Okay, well, yeah, I'm not sure why there. Okay. And well, let's see if it keeps doing this. I bet everyone else used a Mac, right? Okay, let me try that again. Yeah, these things aren't even showing up. I'm not sure why. Okay. I thought we were okay for a minute. Oh my God. Try again. We should close the other. Okay. Anyway, let's see if this works. Okay. There we go. Okay, so there's the images. Thank you. Yes. Okay, and this person was receiving enzyme replacement therapy, and we actually tried topical L-Durazyme to try to clear his cornea for a year, which did not improve things. And went ahead and decided to do DULC surgery for him. But the point being is that there's really not a lot of pathology about patients with MPS and their corneas, but some of the studies did suggest that the endothelium, which is a very important point for corneal transplantation, was essentially free of glycosaminoglycans, and for that reason we decided to proceed with the DULC procedure. So these are the things that we discussed. Keratoprosthesis is an artificial cornea, and we discussed that as well, but felt this DULC modified full-thickness procedure was the best procedure for him. So for those of you, I'm going to show a short video. Hopefully it'll play. If you don't want to watch the video, it's not bloody, but some of you might not want to see eye surgery, so let's see if this works. Okay, it's working. Good. So we tend to do this trephination to get about 2/3 to 3/4 depth of the surgery for the patient. And then the corneas are very thick, so we have to take off part of the cornea, which we're doing here. We're then going to inject this air bubble into the eye, and you'll see this big white spot pop up as we inject the air, and that's the separation between that 3rd and 4th layer. It's quite impressive, and when that happens, then we basically fill that bubble with a jelly material that allows us to remove that cornea. You can see as soon as we're removing that cornea how much darker the iris is because now we were looking through a clear window. We then prepare the graft. We're taking off the 3rd and 4th layer, the 4th and 5th layer of the donor graft, and then we sew it on. And you can kind of see the difference between that central cornea and the peripheral cornea here at the end. So that's the procedure in a nutshell. It usually takes an hour to a little over an hour to perform. This patient did really well after the surgery. Vision improved to 20/25 from 20/60, which is a huge improvement, and his prescription got much less farsighted, and his cornea got a lot thinner. Again, this is his vision, his cornea is pre and post-operative, and you can see how big a difference that is for him. And he eventually had his other eye done as well, and you can kind of see that here. We reviewed the patients who had, our experience with patients who had deep anterior lamellar keratoplasty, and looked at all the cases we could find in the literature. And you can see there wasn't very much. This was 2013. But what's important to note is that everyone had improvement in the vision. This is the second case, which I'll go over and I'll be done in just a minute, who also underwent surgery for DULC and also did very well afterwards as well. You have to consider the pros and cons of these two procedures. They both have some benefits, but in general, we feel DULC offers better outcomes, fewer complications, and have better long-term survival over a standard penetrating keratoplasty. This is some more recent data, which I'll skip over for the sake of time. But in conclusion, ocular findings are common in MPS patients, particularly corneal clouding. Several systemic therapies have increased life expectancy, and there's been renewed focus on quality of life measures such as vision. Corneal clouding and glaucoma and visual deterioration in MPS necessitate regular exams, glasses prescriptions, and if needed, corneal transplantation in certain cases. Both PK, and DULC are very valuable treatments for corneal clouding, but we feel DULC is a better procedure overall, and we're starting to generate a lot more data to suggest that is the case. So large studies aren't available yet, but clear corneas, we have now up to almost 10 years now of patients doing very well with this therapy, but patients who are not receiving any therapy can have opacification. So thank you very much. We have some people in the audience here who are patients of mine, and I'm sure they would talk to you about their experience with DULC in particular, and I'm happy to answer any questions afterwards. Thank you.